Hey everyone, and welcome to our November Town Hall. And we're in for a special treat tonight because we not only have one, but we have two special topics tonight. And it's our executive committee duo of Dr. Ginny Rosselli and Dr. Miranda Wilhelm. So we're glad to have both of them to help take us through both diabetes and immunization updates. So I will turn it over to Ginny.
All right, thanks, Garth. Good evening, everyone. Hope you all are doing well. And I want to say happy Diabetes Awareness Month. So that's why we're having this diabetes topic today. So relationship status, it's complicated. Anything related to diabetes is complicated. And then you add in all the different coexisting conditions and it's super complicated. So what we're going to do is talk through some of those complications. We only have 30 minutes devoted to the topic, which we could talk about it all day. So we'll kind of fly through things this evening. I don't have any declarations related to conflicts of interest for this program today. For the pharmacist objectives, hopefully you'll be able to provide referral recommendations for diabetes-related screenings based on the patient's age, the type and duration of diabetes, if they're presenting with any symptoms or concerning signs, and then provide some risk factor modification and also recommending therapies for those different complications that we'll talk about tonight. For technicians that may be present, what we want you to do is be able to identify common diabetes-related complications and coexisting conditions, as well as identify the different treatment strategies that are used by the diabetes care team to manage those complications. So giving you a preview of the questions that we'll touch on at the end, which of the following diabetes co-conditions should be screened for at or soon after diagnosis of type 2 diabetes? And select all that apply. You can see the choices there, and we'll go through those a little bit slower at the end. What are the two key modifiable risk factors that should be optimally managed to lower the risk of retinopathy from developing or progressing? And then independent of A1C, which of the following glucose-lowering medications is a preferred therapy to prevent progression of chronic kidney disease in people with type 2 diabetes who also have elevated albuminuria levels? All right, so be thinking of those as we go through. I kind of gave you a hodgepodge of statistics here, but what I did was wanted to include the various statistics that show the scope of the problem of these various complications related to diabetes and why they need to be as important as treating glucose levels. And so what we have found through the research is that people who have type 2 diabetes, 98% of them have at least one complication, 89% have at least two complications. ASCVD, atherosclerotic cardiovascular disease, which encompasses coronary heart disease, cerebrovascular disease, and peripheral arterial disease, combined, that is a leading cause of morbidity and mortality for all people with diabetes. And then when we think about the kidneys specifically, the studies are showing that anywhere from 20 to 40% of people with diabetes are experiencing that complication. When you think about the eyes as another common organ that's impacted by diabetes, retinopathy is the leading cause of new adult cases of blindness in the United States. 90% of those cases are preventable. And even more alarming is only about half of people with diabetes undergo the recommended screening recommendations for retinopathy. And then another common complication that we're aware of is neuropathy. And typically when we think about neuropathy, we think about lower extremity neuropathy. And so with that, about 20% of people with type 1 diabetes who have had that disease duration for 20 years experience that complication. When we think about people with type 2 diabetes, that if they have had that diagnosis for 10 years, half of individuals are reported to have lower extremity neuropathy. And so it's pretty sobering when you think about the impact of these different complications on top of diabetes, which is in and of itself often overwhelming for people with that diagnosis. So this represents the various complications. Most of them we've already talked about through the different statistics already presented. Some other ones to highlight include periodontal disease. I'm not going to go through that in detail tonight, but there is a bidirectional relationship between diabetes and periodontal disease. The hyperglycemia induces an inflammatory state, which leads to periodontal disease, and individuals who have periodontal disease have also been found to have elevated A1C levels. There have, in fact, been some dental practices that have implemented some screenings to identify folks that have diabetes or may not have been diagnosed yet. So they're in some practice doing finger sticks for glucose levels or even A1C point of care tests to help identify people who may have diabetes. And I've had some people newly referred to me with new diagnosis that came after they saw their dentist and they were having some dental issues. And they were referred to their primary care for screening for diabetes and found to have the diagnosis. Many other complications or just coexisting conditions that are highly probable in people who have diabetes are listed here. These are not the ones we'll be talking about tonight, but I did want to highlight all the different coexisting conditions that are related to diabetes and people who are on the diabetes care team, which is pharmacists, technicians, student pharmacists. We all come across individuals with that diagnosis that we need to be aware that there's many other factors of disease states that they're perhaps dealing with. And so there's lots of information out there to assist with the screenings and ways to educate patients about these things too. So what I want to start with is atherosclerotic cardiovascular disease related to diabetes. So what's recommended in the American Diabetes Association standards of care is that we need to be measuring blood pressures at every clinic visit that a person with diabetes has. We need to be looking at their cholesterol levels as well at diagnosis and periodically thereafter. And that'll just depend on if they are found to have abnormal lipid levels or if they're started on cholesterol lowering medications, and you're going to be following that more often. Otherwise, usually every 3 to 5 years if they're not on therapy. We need to consider for antihypertensive medications, statins, icosapent ethyl, and aspirin for all adult patients. All these details are found in the American Diabetes Association Standards of Care that's provided with updates every year. It should be coming in about a month and a half. So it's published with the January edition of Diabetes Care, but usually it's released early in mid to end December. For all patients with type 2 diabetes, we need to be thinking about specific glucose lowering therapies that may be also helping to reduce their cardiovascular disease risk. And we'll talk about that in more detail here. So this is a summary of the algorithm for managing individuals who have type 2 diabetes. The first line, the backbone of type 2 diabetes therapy, is metformin, as well as comprehensive lifestyle management. And then from there, it's going to be based on patient-specific factors. So first, we're going to be thinking about, do they already have ASCVD or a high risk for ASCVD? Do they have heart failure? Do they have chronic kidney disease? If the answer is yes to any of this, then we need to be thinking about GLP-1 receptor agonists or SGLT2 inhibitors. If the answer is no, then we have to think about these other factors of like hypoglycemia risk management, weight loss, or trying to prevent any more weight gain, and then cost is another factor. So we're going to be focusing on this left-hand side of the screen here. So to start with the ASCVD indicators, what's recommended is GLP-1 or SGLT2 with proven cardiovascular disease benefit. And so what helps to also provide some guidance beyond what was provided on that algorithm is this algorithm is from the American College of Cardiology practice statement. And what they have put together is pretty specific guidance on like factors to consider between the GLP-1 and the SGLT2 medication classes. Because if the patient has established ASCVD or is at a high risk for that, either or of those drug classes could be utilized. So when we think about the difference between the two, one is where is the functional status of the kidneys. So for SGLT2 inhibitors specifically, it's recommended to not initiate if the estimated GFR is below 30. Okay, so as long as it's above 30, then that's one medication class to definitely consider in this situation. And then the GLP-1 receptor agonists, we can utilize those with even lower GFR levels. The only ones we're not going to be using is going to be exenatide, but those medications do not have proven benefit to reduce cardiovascular risk anyway. Okay, so the GLP-1s that we're going to be looking at for this with proven benefit to reduce cardiovascular risk is dulaglutide, liraglutide, or semaglutide. And then when we're looking at the SGLT2 inhibitors with the proven ASCVD benefit, that includes canagliflozin or empagliflozin. Okay, so we need to have that risk benefit discussion about the different medication options with the patients, and let them decide if there's nothing else swaying you from one or the other. So think about how much A1C reduction they might need as well, if that's the case. And then follow the algorithm in that manner as far as starting with lower doses and gradually titrating from there. The question is, are statins still recommended for primary prevention of cardiovascular events in patients with diabetes? The answer is yes. So we still have the established recommendation for adult patients who are between the age of 40 to 75 years who have a baseline LDL between 70 and 189. So that would be a statin benefit group to start at least a moderate intensity statin. And then there are going to be some factors that might indicate that you would want to escalate to a high intensity statin for those folks, like if they had an estimated ASCVD risk of 20% or greater, or they have other complications present, such as the various opathies, retinopathy, neuropathy, et cetera. Okay, so that was a crash course in managing people with type 2 diabetes who have ASCVD or high ASCVD risk. And those therapies are recommended regardless of what the A1C is, because of the very profound evidence of reducing cardiovascular events in those patients. When we think about chronic kidney disease specifically, what's recommended as far as screening is to evaluate the GFR. So we want to pull the serum creatinine level as well as the urine albumin to creatinine ratio in individuals with type 2 diabetes at diagnosis. We need to do that at least annually. And then for people with type 1 diabetes, we'll start doing that when they have a duration of disease of at least 5 years or more. If someone is found to have an elevated urine albumin to creatinine ratio or a low GFR, defined as less than 60, then we'll need to be doing those screenings at least twice a year. The worse their kidney function or the higher their UACR gets, then the times that we need to be monitoring those different parameters will increase. But at least twice a year when we have those different abnormalities, probably more as it progresses. The mainstay of therapy is we need to optimize their glucose and blood pressure management to help prevent progression. There are some recommendations to watch their protein intake levels. So we don't want to severely restrict protein levels in people with chronic kidney disease. That recommendation was actually found not to be very safe in individuals, and especially once they get to dialysis, there's more of a risk for malnutrition than anything. So we want to make sure that they're being referred to dietitians to help with management to prevent malnutrition, and even consider higher levels of protein intake for those individuals. But we don't want people to restrict beyond the 0.8 grams per kilogram per day of protein intake. The recommendation for ACE inhibitors or angiotensin receptor blockers is going to be for individuals with elevated urine albumin to creatinine ratios defined as 30 or greater, or when they have chronic low GFRs, meaning that it's less than 60. We also want to have people with type 2 diabetes utilizing metformin and strongly consider the use of SGLT2 inhibitors or GLP-1 receptor agonists if there's a reason why the SGLT2 couldn't be utilized. I do want to mention this algorithm that was added to the KDIGO guideline for managing chronic kidney disease in individuals with type 2 diabetes. What the recommendation is currently is to try to avoid stopping ACE inhibitors or ARBs unless absolutely necessary because of the known benefit for preventing progression of chronic kidney disease or reaching dialysis. So this means if someone is experiencing hyperkalemia, or there's an increase in creatinine levels, we need to try to correct for other causes, which is indicated in these boxes here, before reducing the dose or even stopping the ACE or ARB. And I think we've all probably seen in practice where these medications are probably stopped sooner. People jump the gun a little bit on that just from getting a little nervous when you see high potassium levels or a pronounced increase in creatinine level. But the recommendation here is really highlighting to consider these other factors, such as, are they on diuretics? Do we need to back off on their diuretic doses? We need to look at dietary potassium intake as a way to help manage hyperkalemia or increases in creatinine, looking at volume depletion, things like that, before getting to the point that we're stopping therapy. All right, so focusing in on what the ADA guidelines recommends in terms of managing with glucose lowering therapy for people with type 2 diabetes and have chronic kidney disease. So what the recommendation is if albuminuria is present, so that UACR is 30 or greater, then the SGLT2 inhibitors with evidence of reducing chronic kidney disease progression is recommended. The GLP-1 receptor agonists are going to be the alternative medication class if the SGLT2 inhibitor couldn't be utilized. If we have someone that has chronic kidney disease, but not albuminuria, so that would mean their estimated GFR is below 60 on a chronic basis, but their UACR is still in the normal range, then either the GLP-1 or the SGLT2 could be utilized. And that's based on the evidence showing that people with elevated albuminuria levels seem to have more pronounced outcomes and prevention of progression when they're on SGLT2 inhibitors. All right, and so this is another algorithm that helps break down exactly different factors to consider when it comes to metformin use and SGLT2 inhibitor use in people with chronic kidney disease. So it provides that guidance as far as the GFR limitations for use of metformin. Remember, we're using GFR thresholds instead of serum creatinine thresholds now for metformin use. So we can certainly initiate metformin as long as the GFR is above 45. If they have already been on metformin and their GFR falls below 45, we can still continue it. You just may want to reduce the dose to prevent side effects. They're going to be more prone to some of the GI side effects, particularly when their GFR starts to decline, but we need to absolutely discontinue it once the GFR falls below 30. And then this walks you through what we already talked about in terms of albuminuria being the determining factor of when SGLT2s are the highest recommendation for use versus GLP-1 or SGLT2 is the option in that case. The SGLT2s that have that compelling indication currently for preventing progression of CKD include canagliflozin and dapagliflozin. The trial with empagliflozin is currently underway. It should be completed in 2022. So we'll see if we start noticing that class effect, which we as practitioners kind of expect that is coming, but that will be determined once that evidence comes out next year. All right, so getting into diabetes-related retinopathy. This is a pictorial representation of what a healthy eye looks like and what retinopathy eye looks like. What happens with diabetes-related retinopathy is, what we start to see is, damage to those blood vessels. They start to become leaky, and over time, the edema starts to develop. As it progresses into proliferative retinopathy, then that's where there starts to become the abnormal growth of new blood vessels or neovascularization, which you can see here compared to here, we don't have those different vessels. So the eye is developing these brand new vessels, but they're not healthy blood vessels. They're weak blood vessels, they're leaky blood vessels when they're more easy to bleed. And obviously blood in the eye causes vision impairment. And so what we start to see is the cotton wool spots. It drastically changes the field of vision and ability to see. And as we had already stated earlier, how retinopathy is the leading cause of blindness among adults in the United States. So it can lead to severe complications that can make it very difficult for patients to take medications, stuff we deal with every day where they're not able to adequately read their labels or the information that comes with their medications. When it comes to injections, they may not be able to see very well exactly how they're supposed to inject. A vial and syringe can sometimes become impossible to use because of the small markings on the syringes and the numbers on the syringes. And so we want to make sure that we're noticing these things with our patients, we're asking these questions, and we're getting them on the appropriate therapy. The best thing we can do is talk early on about early screening and identification of retinopathy, because as it starts to develop, the patients don't have any changes in their vision. It's as it progresses to those more proliferative stages that they start to notice those vision abnormalities. And at that point, it's very difficult to provide any type of regression in the disease. It's often just treatment to prevent progression and further vision loss. So the mainstay of managing retinopathy is optimizing glucose, blood pressure, and cholesterol management. Again, trying to prevent the complication before it even starts. Therapy, once there is a significant abnormalities and significant retinopathy changes. We have the intravitreal anti-VEGF agents, which really target that abnormal growth in the blood vessels. And then we have options of intravitreal corticosteroids. These are not recommended to be utilized on a chronic basis because they can cause development of cataracts, but they are an option to use on a short-term basis. All of this is utilized, again, intravitreal, so either through injections, which is the anti-VEGF. The corticosteroids are either injectables or implantable treatment. Last line therapy is going to be the vitrectomy surgery, but we often see people undergoing laser treatment, and sometimes they have laser treatment as well as the anti-VEGF injections. I sometimes have probably more complaints from patients come back after laser treatment that they experienced a lot of discomfort during the treatment and after the treatment, but it has been shown in some cases to help regress the disease a little bit. We want to avoid retinal toxic substances. And so I'll have a slide in a second that just reviews some of those medications that are toxic to the eye that we want to be thinking about, especially as medication experts. Prevention strategies are listed here. The most important ones are achieving target blood pressure and glucose management. And that's been shown to help prevent the disease as well as prevent progression. Other factors that have been shown to improve disease state with retinopathy include body weight management, reducing sedentary time to no more than 30 minutes, increments. Reducing the risk of kidney disease has also been shown to reduce retinopathy, managing serum lipid levels as well. The screening recommendations are listed here. So initial screening for retinopathy for people with type 1 diabetes will start 3 to 5 years after diagnosis of a child or adolescent. For adults, it's going to be 5 years after diagnosis. And then follow-up is going to be every 1 to 2 years. For type 2 diagnosis, it's going to be a retinopathy screening right away or soon after. Pregnancy is one of the conditions that is highly related to causing retinopathy, and so that's why there are specific recommendations for pregnant females who have diabetes to have pretty frequent retinopathy screenings during the pregnancy. The different medications that are associated with retinopathy are listed here. The anti-malarials, this, I know you guys are probably sick of talking about these things and the different risks since they've been abused during the COVID pandemic. But when it comes to retinopathy, the risk is more related to chronic use of these medications. So the longer the patient is taking these, which years of taking the medication is associated with causing retinal toxicity, and the higher the dose of these medications is associated with it as well. Other medication classes are listed here just to highlight some things to be thinking about and trying to minimize use if possible in people with diabetes, especially those who already have retinopathy. The different glucose lowering therapies that can increase the risk for retinopathy are listed here. So GLP-1 specifically, there's warnings on the package labeling for semaglutide, dulaglutide, and liraglutide. It also showed in their cardiovascular outcome trial as a secondary outcome, looking at microvascular risk, and retinopathy specifically was an increased risk in people who were taking liraglutide versus placebo in that trial. So what's recommended is to ensure that people on GLP-1s are undergoing regular screening for retinopathy. We definitely need real-world studies to identify exactly how prominent of a problem it is or may not be in individuals who are taking GLP-1 receptor agonists. All right, diabetes-related neuropathy. We often think about the lower extremity neuropathy, which is defined as distal symmetric polyneuropathy, but other types of neuropathy to be aware of are the autonomic ones. And there's many, many of the autonomic neuropathies that I listed here. Most concerning is the cardiovascular ones, because this is where individuals with diabetes who have this complication can experience silent myocardial infarctions and death. And so how it often presents early on is resting tachycardia, orthostatic hypotension, exercise intolerance. I think we're all pretty aware of gastrointestinal complications, specifically gastroparesis, but urogenital issues that affect the bladder as well as sexual function in both males and females is very common in people with diabetes, as well as issues that affect skin and the tolerance to heat and sweating. It could be an absence of sweating, or it could be excessive sweating. We're going to be screening for the lower extremity neuropathy in people that have type 2 diabetes at diagnosis, and annually thereafter. People with type 1 diabetes will start 5 years after diagnosis. Anyone who has a history of amputation of ulcers, we should be at least doing feet inspections at every clinic visit, just to see if there's any current problems or need to refer the patients out for wound care, antibiotic use, etc. This is a crash course in the various treatments for all the different types of neuropathies. I will not go through all these for the sake of time, so I don't take any more of Dr. Wilhelm's time tonight. But I did want to include this more for completeness sake, so you all will have access to these slides and can refer to this on your own. The take-home points is we absolutely have to target the background problems of people who have diabetes to help prevent complications as well as prevent progression of complications. So optimal management of glucose levels, blood pressure, and cholesterol. And then, we need to be working together with other healthcare professionals to identify as well as manage the various complications and coexisting problems that people with diabetes have, because it takes a village to take care of an individual with diabetes because of all these different factors. Making sure that we are talking with patients, educating them on these different factors that may be related to their diabetes, helping manage their medications appropriately, is going to be key for the pharmacy staff. The different resources that are available to you, I have hyperlinks that can take you directly to the ones that I used for these various slides. The ADA guidelines, again, be looking for that update in about a month and a half from now. American Association of Clinical Endocrinology has their own set of guidelines. It's kind of erratic as far as how often they get updated. American College of Cardiology, that algorithm, that document, link is there for the ASCVD risk. The kidney disease guidelines, the link is there. They have some great new ones out there for both hypertension and the management of CKD and type 2 diabetes. The neuropathy position statement is a good source. It's starting to get a little outdated. It was published in 2017, but the link is there as well. And then the Association of Diabetes Care and Education Specialists has a screening checklist for all these different coexisting conditions that might be useful for you to take a look at and have an idea of what should be screened on a regular basis for people with diabetes, both type 1 and type 2. So getting to the post-test questions, which of the following diabetes co-conditions should be screened for at or soon after the diagnosis of type 2 diabetes? Select all that apply. So please put your answers in the chat. A, retinopathy, B, peripheral neuropathy, C, gastroparesis, D, cardiovascular disease, or E, kidney disease. I got people saying A, B, D, E. All right. So A, B, and E. Okay, there's not any recommendation to do screenings for cardiovascular disease. This is only going to be based on an individual presenting with concerning symptoms. Same thing with gastroparesis. We're not going to preemptively screen for either one of those. All right, I'm trying to move my chat box out of the way so I can read this. Which are the two key modifiable risk factors that should be optimally managed to lower the risk of retinopathy developing and or progressing? A, dietary sodium intake and serum lipid levels. B, low vitamin C and ocular sun exposure. C, high blood pressure and glucose. D, high blood body weight and sedentary lifestyle. All right, you guys are smarties. High blood pressure and glucose are extremely important in managing those risk factors. All right, and finally, independent of A1C, which glucose-lowering medication is a preferred therapy to prevent progression of chronic kidney disease in people with type 2 diabetes and albuminuria? A, metformin, B, exenatide, C, sitagliptin, or D, canagliflozin. All right, these are winners. Canagliflozin is one of those medications for albuminuria and type 2 diabetes. The other one being dapagliflozin. And stay tuned on empagliflozin. We'll find out hopefully about a year from now. All right, any questions that I can try to answer for you this evening? Okay.
Go ahead, Ed.
Thank you so much, Jenny. I wanted to thank you actually for great timing on this topic, the month of diabetes. So I also attended Starlin presentation on telehealth. I'm kind of curious if we put the two together, given that Healthy People 2030 listing diabetes is one of the goals, do you see a possibility for maybe decreasing the prevalence by addressing the pre-diabetic patient through telehealth, perhaps using some of those sessions for patients who normally would not be able to transfer to sites or visit the physicians? What are your thoughts?
Oh yeah, absolutely. And I mean, I think that the model that Starlin is, working on within the state and helping, more and more pharmacists get involved with is definitely a pathway to increase the access for people who are at risk for diabetes to start to receive education and implement those necessary lifestyle factors that are going to help prevent progression to a diagnosis of type 2 diabetes. Absolutely. And I think the majority of people who are in the pre-diabetes category or high risk for type 2 diabetes category are busy or have so many factors where it's hard to physically go to a location. And now you add in the pandemic where it may not be safe to always go in person. And so I think that's just going to increase the opportunity for people to receive that kind of care. And then the model of where they can start to go through these different modules at their own pace, I think is even more enticing for the normal busy adult person.
I just want to throw in there that the ophthalmologists actually have some tools that they can utilize through the visual aids of smartphones and some of the things to do some eye checks. It's not as perfect as in their machinery that's in their offices, but they can do some screenings, and that's that's going to be even better as we progress and we get more digitally confident. So.
Yeah, absolutely. I've had a lot more patients who are receiving at-home screenings now with the, I forget the technical word for it. I think I had it on my retinopathy slide, but the photography type of retinopathy screening where
they put their eyes all the way up into the thing, and it's very cool. It's kind of like when you go through clear.
And so, if any abnormalities are identified through that type of screening, then they'll refer the individual to go to a local office. But, how convenient is that they're going to the patient's home to do that initial screening?
Yep.
Hey, Tom, you have your hand raised. You can go right ahead. Oh, we're trying to unmute you there, Tom. There you go.
Have you ever seen any information relating diabetic neuropathy and trigeminal neuralgia?
As far as the diabetes side of it,
As far as they might go together, or?
Yeah, I haven't come across that with diabetes, but I haven't specifically looked for it. But it hasn't come up in just kind of the general information that I've perused through.
Yeah. Okay.
So there's a correlation of trigeminal neuralgia and shingles that come out of the trigeminal nerve, and the retinopathy that's associated can do that. And if someone has diabetes on top of it, then that just increases the risk. But we've seen more trigeminal neuralgia, retinopathy with COVID than which kind of acts the same way with high blood sugars. So there's probably some more research that needs to be done in that area.
Yeah. Okay.
Arnold, I see that you're unmuted. Did you have a question? Okay. Oh, Tom, did you have another question, or did you raise your hand again by accident? Okay. All right. Let's see here. Here's all of Jenny's references for your bedtime reading. Thank you very much, Jenny.
Thank you.
We will give the evaluation link and the code and reminder for tonight. There will be 2 codes, one for each program. And so but we'll give that to everyone at the very end. So Miranda, it is now your turn, and to give us an update on just a little bit of the information that's come out in the last couple of days on COVID vaccines.
Thank you. Yes, I have been busy for the last couple of days with all the updates to that. So our other discussion for this evening is our COVID-19 vaccine update, 3rd dose boosters, and then the recent information about pediatric patients. So I do have a disclosure. I would like to report that I am an expert in residence for CE Impact, and that involves writing CE modules for them. I have 2 learning objectives for the pharmacists. One is to be able to identify candidates who are identify patients who are candidates for the 3rd dose and then booster doses, and then describe the newest information around the recommendations for COVID-19 vaccines in kids 5 to 11 years of age. And the same for any pharmacy technicians that have joined us as well. So here's our first pre-assessment question. Which of the following patients is a candidate for a COVID-19 booster? And so we need to be specific with our terminology here. A 14-year-old female who received the Pfizer BioNTech 2-dose vaccine series in June. A 30-year-old female who received 1 dose of the J&J Janssen vaccine in February. A 45-year-old male receiving chemotherapy who received Moderna 2-dose series in April. Or a 68-year-old male with COPD who received a Pfizer BioNTech 2-dose vaccine in August. All right, and then our second question. What is the dose of the Pfizer BioNTech vaccine for a child 5 to 11 years old? We have A, 10 micrograms or 0.2 mLs, B, 30 micrograms or 0.3 mLs, C, 50 micrograms or 0.25 mLs, and 100 micrograms at 0.5 mLs. All right. So I think important part for us is to use the correct terminology with our patients. So the first thing is we want to have kind of a differentiation between what's a 3rd dose versus what's a booster dose. And so just to give kind of a definition, a 3rd dose is like an extra dose of vaccine that is given after the primary series when the immune response is insufficient. So we're basically trying to get the patient to seroconvert so that they have the same protection as patients who receive 2 doses. So we do this with other vaccines where like there's a small percentage of patients that don't seroconvert after 1 dose. And so then we just give patients a 2nd dose to help get everybody up to speed with that. So this additional 3rd dose with the mRNA vaccines helps to increase the likelihood of developing a sufficient immune response. And so a lot of patients with this 3rd dose get a similar immune response to other patients with just 2 doses. And then a booster dose is an additional dose of vaccine that's administered after a patient has had sufficient immune response to the previous doses and immunity has started to wane over time. And so then we're giving them a booster to kind of reinitiate that immune response, remind the body of that particular antigen, and then they'll have a similar response with that. So we're going to talk about doses first. The reason why we got the 3rd dose. So we looked at kind of some specific groups of patients that are immunocompromised, and they found that they weren't mounting as large of an immune response as a healthy individual. And so that's what this graph shows. Across the bottom, we have different types of immunocompromised status for patients. We can see cancer, dialysis, organ transplant, and then immunosuppressive therapies, which would be like our medications. And then on the x-axis of the graph, we're seeing the percent with antibody titer responses. And then the kind of navy blue dashed line across the top is a healthy control. And so those patients, after 2 mRNA vaccines for COVID, had 95 to 100% efficacy. And then we can see our patients along the x-axis a lot of times didn't get that if they were immunocompromised. And especially the organ transplant, we can see the best they got was 80% after 2 doses, but most of the patients were less than 60%. So this kind of helps to show why these specific patients need that 3rd dose. And that helps them to get up closer to that 95 to 100% of a healthy control with 2 doses of the mRNA vaccine. So this is the CDC recommendations related to who should get a 3rd dose of an mRNA specific vaccine. So that could be either the Pfizer BioNTech or the Moderna vaccine. But they recommend patients who are moderately or severely immunocompromised receive a 3rd dose. And then they've listed, and you can see it's a repeat of what we just saw, like transplant patients, cancer patients, and then those who are receiving corticosteroids or other drugs that suppress their immune system. And so that would include like tumor necrosis factor alpha drugs, alkylating agents, others like that. So a 3rd dose should be administered at least 28 days, and that's for either vaccine after the 2nd dose is completed. And it's best to utilize the same mRNA vaccine as that was for previous doses, but if you got Moderna and it's not available at that time, you can go ahead and receive the other vaccine. So it's best to stay with the same, but if you have to switch, that's okay. All right, so then we're going to talk about who's a candidate for booster doses. So this is different based on the type of vaccine. So for the Pfizer BioNTech and the Moderna, because they are both the mRNA vaccines, they have the same recommendations, but it is a little bit different for the J&J vaccine. So our group of patients who are candidates are those 65 years and older, those 18 and older who live in a long-term care setting, those 18 and older who have underlying medical conditions, and I have those listed on the next slide, and those 18 and older who work or live in high-risk settings, and again, I have that detailed on the next slide. I do want to point out that the CDC is saying that like live in a high-risk setting is, I know we're having this on our campus, is that the dorms are being kind of defined as a potential high-risk setting. Similar to like a long-term care, it's a congregate living environment. And so there's lots of people kind of sharing the same space, which means transmission is going to be much easier. So just kind of keep that in mind when you're thinking about work and living situations. So this is the definition. You guys can see underlying medical conditions. It's most of our chronic disease states. We have heart disease, lung disease, kidney disease. Those are a few others kind of specific with the dementia, Down syndrome, HIV, but for the most part, it's your standard chronic medical conditions. And then our work in high-risk settings, that includes first responders, which also includes like physicians, because if you're just thinking EMTs, it's more than that. So this is doctors, pharmacists, nurses, all of your healthcare providers fall into this category. Also, police officers and firefighters also were considered first responders as well. And then education staff, that included teachers, but also staff and custodial workers and just kind of other daycare workers, anyone else who worked in an education setting. And then we can kind of see some of the others who are considered high risk. It's basically anyone who deals with the public potentially in a high capacity. So like food service workers, grocery store workers, those kinds of things. So the recommendations for the booster doses with the Pfizer BioNTech, it is at least 6 months after the 2nd dose. And then it's a full strength booster. So you get the same dose as the previous 2 doses. The Moderna had to mix it up a little bit. So similar time frame, 6 months after your second dose, but their study that they used was a half dose booster. So it's a 50 microgram, 0.25 ml instead of the 100 microgram for the first 2 doses. And then the J&J Janssen recommendations are different. So it's for anyone 18 years of age and older receive the vaccine. There is no eligibility requirements. Everyone who received J&J is a candidate for a booster dose. They studied 2, 4, and 6 months, and the ACIP selected the at least 2 months, at least 2 months after that primary single dose vaccination. And so this is kind of interesting because it honestly makes this like a 2-dose series instead of a 1-dose series, but they're calling it a booster instead of a 2-dose series because J&J wants to be able to market it as a 1-dose vaccine. And then it's a standard full dose, 0.5 mL, same as the previous dose. This is kind of small, but this is the IPHA COVID vaccine algorithm, and it is really helpful. So I would suggest like printing it on a full-size sheet of paper and having it so you can answer questions. And I've included it in the links at the resources at the back of this slide deck. But I do want to point out one section that has changed over the last few weeks. And so if you can read it, it starts here in the center. And so they're asking if you've had a previous dose, and then you say yes, and then you say which vaccine you've had. And if you've had Pfizer or Moderna, then this is the section that's talking about immunocompromised patients who need that 3rd dose. And so it says, are you immunocompromised? And then gives directions like yes. And then it asks if you've gotten the 3rd dose. And if you have, then it goes to the left and says yes, and it suggests they receive a booster dose as well. So previous to this change in the recommendations, you were only supposed to be able to give 3 mRNA vaccines to any patient like in their lifetime at this point. And this has changed. So if you're immunocompromised, you could receive 4 doses. Your 2-dose primary series, the 3rd dose to help them get to kind of a complete primary series. And then 6 months later, they could receive a booster dose. So just keep that in mind that now the maximum limit that we're seeing is 4 mRNA doses in a lifetime. So just be careful with that because I think there could be a lot of confusion. And this algorithm is really helpful for figuring that out. So I would highly suggest printing it out. All right, and then the news of the evening is the pediatric COVID vaccine recommendations. So I thought I got to listen to some of the call yesterday where the ACIP was debating this topic. And one of the interesting parts that they talked about kind of early on was how this compares to other pediatric vaccines for preventable diseases that we have. And so the top part here, the top table lists hospitalizations for these various diseases before the vaccines were available. And so we can see like Hep A, we have less than 1 hospitalization. Varicella, we have 4 to 31, and influenza 30 to 80. And so COVID fits right in with those other vaccine preventable diseases with 25 hospitalizations per year. And then kind of remarkably, the deaths before vaccine. So Hep A, we had 3 deaths on average per year before the vaccine. So not necessarily that prevalent for requiring hospitalization and death. Obviously, the disease is highly prevalent. You can see the other ones. We had 8 meningococcal, 16 varicella, 17 rubella, rotavirus 20. And then COVID just from the last year in kids 5 to 11 years of age, we've had 66 deaths. So this is definitely showing us that we need a vaccine for this age range and that it is probably comparable to other vaccine preventable diseases, if not better in some of those instances with the number of kids that are dying. So this is the data that was presented to both the FDA and the CDC from Pfizer. This is kind of the efficacy on this slide, and then I have safety on the next slide. So it was a phase 2/3 clinical trial. The initial enrollment was just over 2,000 participants, and they were to be randomized to a 2-to-1 ratio to receive the vaccine versus placebo. And then the FDA, after we had those myocarditis things come out with the side effects, they said, we need a safety expansion. And so they basically doubled the number of participants in the trial, again, in a 2-to-1 ratio, vaccine to placebo. The trial, in the phase 1 trials, they figured out what microgram dose to use. So in the phase 1s, they did 10, 20, and 30. And they found that the 10 microgram dose gave robust immune response with reduced side effect profile for kids. So that's why they went with the 10 microgram 2-dose series administered 21 days apart. And then I do want to point out that this was for the EUA to be approved. The FDA said they could do a bridge immunologic approval. And what that means is that they just had to compare the immune response of the 5 to 11-year-olds to what they got for titers in the 16 to 25-year-olds. And as long as the immune response met non-inferior criteria, then the vaccine would be approved. And they didn't have to follow incidence of COVID in the vaccine participants. The Pfizer went ahead and did that, but it wasn't required for the EUA to be approved. So efficacy that they found is the vaccine is 90.7% effective in kids 5 to 11 years old, 7 days after the second dose is given. There were 3 cases of COVID-19 in the vaccine group and 16 cases in the placebo group. And then they did meet that non-inferior criteria for the immune response. It was almost identical to that of the 16 to 25-year-old participants. For our safety information, if you look at it, local reactions after both doses, the most common things that we saw were injection site pain, redness, and swelling. Those were more common than placebo. And if we think about what adults and adolescents we've seen with those patients as well, it's very similar. The systemic adverse events after dose 2 were fever, fatigue, headache, chills, muscle pain, and joint pain. Those were the ones that were more common than placebo. And again, when you think about your adult patients, these are similar things to what they're complaining about as well afterwards. I do want to point out that there was no cases of myocarditis, which is one of our concerns with these vaccines, especially in younger male patients. But this study was not powered to assess the risk of myocarditis, and with only having about 4,000 participants, myocarditis is rare, and we'd have to give more doses than that for an instance to occur. So it really wasn't powered to address that, but still we didn't see any of that rare event in any of this clinical trial. And then also, I know early on we saw that MIS, multi-system inflammatory syndrome in kids. There were no cases of that with the vaccine as well. So the safety profile looks pretty similar to that of the adult profile. So here's the part that we need to be aware of, because the kids dose has been reformulated. So you can't just draw 10 micrograms out of the adult dose. You actually have to use a separate vial because they changed some of the buffers in it, which is good for us because it can stay refrigerated longer, but it means that they're not exactly the same vaccine as the adult. So the first thing is going to be different is the color. The one we're using now for 12s and older is the purple cap. And now you're going to have to use the orange cap for the pediatric formulation. It's also going to have an orange bar around the label so that once you pop that cap and it goes in the trash, you can still identify the orange bar on the label to help know that that is the pediatric version. The dose is less at 10 micrograms. The injection volume is less at 0.2. So definitely be careful and double check that you've pulled the right amount out of the syringe. You also have to dilute with a different amount of saline, so be careful with that. And then the storage requirements are different. It can be up to 10 weeks in the refrigerator, which is helpful. And if you guys got the Vax Facts tonight, or I got a report from Siren, they just want everyone to know that the date that is being printed on the vials is the manufacture date, not the expiration date. So the vials do not have an expiration date on them. It's whatever the manufacture date is plus 6 months. So when that comes out, just kind of be careful. We've already had kind of a warning about mistakes occurring with that. And then I wanted to talk a little bit about the vaccine dosage, because there has been some questions like kids 5 to 11. What if they turn 12? And now should they get the adult dose? Should they get the kid dose? Like, what do we do? So children should receive the age-appropriate vaccine formulation regardless of their size or weight at the time that you're giving the vaccine. So if they are 11, you give the new pediatric formulation. And if they have a birthday in 21 days, then you're supposed to give them, when they turn 12, the adolescent adult dose. So just definitely watch for that and make sure that you're basing it on their age at the time of vaccination. And the reason for this is that vaccines are dosed based on the maturity of the immune system and not on the size or the weight of the child. So it doesn't really matter how much they weigh, it's more about their age. And there have been some nice information provided by the ACIP that, like, it's not a mistake if you give them the pediatric dose when they're 12. There's nothing that magically happens when you go from 11 to 12 and your immune system like goes into hyperdrive or anything like that. So that will help us if we do make errors, but I think it's best to just from the beginning, dose it based on their age and you'll be fine. So a summary, we talked about who is a candidate for the third dose of the mRNA specific vaccines, and that's our moderately to severely immunocompromised patients. And we want to make sure to give that third dose 28 days after they complete the 2-dose series. A booster dose, which is different, of the mRNA vaccines is recommended. And we talked about kind of the different groups that fall into those high risk categories. That is given 6 months after their second dose. And then to the J&J vaccine, everyone is a candidate for that. So 18 and older who receive J&J should receive a booster dose 2 months after their first dose. And then the last part we talked about was the Pfizer BioNTech vaccine receiving both FDA and CDC approval. The CDC yesterday for kids 5 to 11, and we kind of talked about some of the information that we need to be aware of in the pharmacy for that. All right, let's try our post-assessment questions. So which of the following patients is a candidate for a COVID-19 booster dose? We have our 14-year-old female who received the Pfizer 2-dose vaccine in June, our 30-year-old female who received 1 dose of the J&J vaccine in February, a 45-year-old male receiving chemo who got 2 doses of Moderna in April, and our 68-year-old patient with COPD who received the Pfizer 2-dose series in August. If you guys want to type your answer in the chat. I see a few votes for B. Okay, so B is the correct answer. We can go through why that is. So the 14-year-old is not a candidate because it's all 18 plus. So they're too young a booster dose at this time. And then June, 6 months later, would be December. So we're not quite far enough along if they were a candidate with the 6 months hasn't elapsed. So for our option C, the reason that that's not correct is our wording. So the difference between a third dose for our immunocompromised patients and a booster dose. So just making sure that you're paying attention to the wording and using that correctly. And so that's the reason for that one. They would be a candidate for a third dose. And that does make a difference because the Moderna vaccine would be a full strength for the third dose, but a half dose for the booster. So just making sure you're giving the right amount as well. And then our COPD patient in August, it hasn't been 6 months yet, so they would need to get a booster dose in January timeframe. All right, and then our post-assessment question 2, what is the dose of the Pfizer BioNTech vaccine for children 5 to 11 years old? We have 10 micrograms, 30 micrograms, 50 micrograms, or 100 micrograms, and I'm seeing the A's run up on my chat. So that is great, that is correct. We've got that new lower dose for the pediatric patient, so just be careful. All right, these are some resources. The APHA source is on here for that algorithm, which is great. That is the top one. And then just a few other places where you can get information from the CDC specifically about boosters and the third dose for patients. All right, I saw a couple questions come in. I'll scroll through the chat to kind of see those, but you're welcome to like holler out questions as well. Now those are all way at the top.
Remember, you can raise your hand and we can unmute your line. Abby, go right ahead.
Thank you so much, Miranda. It is exciting that we have the vaccine available for those who are 5'11". I don't think anybody on the webinar qualifies for that, but we might be parents. So what would your message be for the parents about safety and the importance of these vaccines for the children?
I think that's a great question because I know parents are concerned about safety for their kids, and that makes sense. I think the fact that the side effect profile that we're seeing is so similar to the adult profile that if the parents got the vaccine, you can tell them your kids will experience probably the same things that you did. And so that I think is reassuring to them. And then they know how they managed those side effects when they had it. So like if they had to take Tylenol, then they just are prepared to help their kids, identify that they're having a headache or whatever and give them an antipyretic if needed.
Thank you, Abby. Rupesh, I think you got your hand raised.
Hey everyone, how are you? I hope you're doing well. Quick question. Are we supposed to edit our consent form for COVID for pediatric patients?
I think that depends on what your consent form says. If it has like specific ages on it, then you are going to have to update that to be able to include the kids on that.
Thank you.
I have a question in the chat from Linda that says, what if someone who comes to the pharmacy and asks for a booster dose and had an organ transplant, so they're falling into our immunocompromised status and they qualify for a third dose? Could that be considered a third dose even though they took the booster dose after 6 months? So yes, it can be considered the third dose for immunocompromised patients. It's best if we can get 28 days so that they get the immunity as soon as possible. But this recommendation was only a couple months. I know that a lot of people had previously received their vaccine in like January and February. And so it's been way past that 28-day time frame. So yes, you can give the third dose at any time. It just has to be at least 28 days and you can call it a third dose even though it was more than the time frame. So immunocompromised patients receive the full strength third dose of either the Pfizer or the Moderna. And that kind of answers a question that we had in the chat from Sam.
Miranda, there was 2 questions from Phil that are very recent in the chat that I think are very pertinent to some of the question encounters we may have.
Great. Down. Oh, I see a question from Philip. about when can a booster be administered if the patient was fully vaccinated but had a breakthrough COVID infection? And that's a great question. So the recommendation is that if someone's had COVID, they have to be symptom-free to be able to receive vaccine. So kind of however long that takes, if that's the 10 to 14 days and they're symptom-free. And they do probably have some kind of natural immunity for at least 90 days afterwards. And we're seeing that, you know, in some patients it's longer, in some patients it's shorter. So the recommendation now is to give the booster dose after they have been symptom-free. We do know that natural infection will not protect you. And did you guys see the new infographic that shows that if you've been vaccinated, or if you're not vaccinated, you're 5 times more likely than vaccinated people to get COVID. So we know that natural infection doesn't last.
And then Miranda, I think Philip had a follow-up with when may a booster be given if the patient had received monoclonal antibodies?
Okay, that's a great question. I believe that is at least 90 days as well, but I haven't been keeping up with that. So if anybody else is like more on top of the monoclonal antibodies, that would be great to add in. I welcome that comment.
So yes, 90 days.
Just wanted a confirmation.
Yes. And hopefully we'll have that finished soon. The vets have a playbook that you can download. Garth, do you have that link? If people want
there will be an Illinois CE version that'll be available shortly. So if anyone's interested, we need pharmacies contact in the office. So.
Yep.
Miranda, Cody's got a great question about mixing of the vaccine brands. And we know that's been a very interesting topic. And I think you kind of touched on it a little bit in your slides.
Yeah, so that's a great question. And I thought this was really interesting because there is a study where that's what the ACIP reviewed. It's out of Texas. There's an author that's the main author on that study. And so they looked at combination products. The N of this study for comparing the mixing and matching of booster doses is less than 500 people. So there were 9 out, like the 9 different groups to be in. And so there was basically 50 people in each group. So just keep that in mind when you think about making decisions. A very small sample size, not powered to be able to tell us the difference between combinations and which combination is better. It's just to show that if they did use a mix and match booster dose, that they did mount an immune response and it was sufficient. So I'll tell you what I told my neighbor, because my neighbor got J&J in like February, March timeframe. And so I told her to get Moderna so that she could get some mRNA boost from that. Also, she's in the age range where the TTS is a possibility for her. And so I thought an mRNA vaccine would be safer for her anyway. But at the time when she got her vaccine in February, March, like the correct answer was whatever COVID vaccine they're giving the day you go is the one for you. So she did a fine job with that. That was what happened to be given the day that she went. So, but I'll tell you, all HIPAA myself, I got my booster dose and I went ahead and went with the same one that I had already received. So I think you want to think about the risk profile. If it is a young male, maybe you want to recommend J&J because they're less likely to get that myocarditis. And if it's a young female, maybe you want to recommend an mRNA vaccine because they would be less likely to have the TTS with them. So think about side effect profile and which would be safer for the patient based on their age. All of them, like mixing and matching, all of them a good response. So everybody got a boost after those extra doses were given in the trial.
Miranda, I know we've had a lot of questions come in. One of them was, if the patient didn't receive their second dose within either the 21 or 28 days, would they need to restart the series? Is there a cutoff time for that? Because I know we've talked about that with some other vaccines about restarts.
So at this point, there is no recommendation to start the COVID series. You just give the next dose when. So if they're past the 21 or 28 for Pfizer and Moderna respectively, then you just give it. And then you could give, if they're a candidate for like that third dose or booster dose, try to get them back on time for those doses. But there's no need to restart at this point. Oh, this is a good question. So the patient who got J&J, do they get a full dose of Moderna? So the question, like related to this, is that it's being considered a booster, and the booster approval for Moderna is the 0.25, the half dose. So if it's booster, they should get the half dose, not full.
I think that may be all the questions.
Okay. Great.
And I'm going to pause the recording here so I can put the evaluation link in your codes. I'm going to put them all together here so you'll see that.